third speaker. Hi, Dr. Tan Min Min, who's Research Fellow from the Jeffrey Chia School of Medicine and Health Sciences, and she's attached to the Southeast Asia Community Observatory, or SICO. And she will bring her public health expertise to her topic for this seminar. Min Min, the floor is yours. And please make your slides big.
Okay, let me share screen. Okay. Yeah. How does religion work during the COVID-19 pandemic? Social distancing is crucial in preventing the spread of the disease. However, many religions require the believers to congregate, and many people turn to religions to cope with stress due to COVID-19. In Malaysia, 98% of the population has a religion, and religion is part and parcel of our lives. The religious communities in Malaysia have never experienced such pandemic and were caught off guard by the sudden change of their religious routines. Disease prevention measures, such as social distancing without due consideration of religion, will be met with resistance. In the case of COVID-19 in Malaysia, the greatest challenge is to implement preventive measures that are religiously acceptable by the diverse religious groups in the country. Engaging religious institutions in public health planning would help in reaching out to the people. Here, I would like to make a few recommendations to promote a partnership between the healthcare system and religious institutions, especially during a pandemic like COVID-19. Usually, health promotion is need-based, so we diagnose what is lacking. So we should move towards an asset-based approach to find out what is already there for public health. And religion is a health asset that is readily available for health promotion. One of the most important religious health assets will be the religious leaders. For the partnership between the healthcare system and religious institutions to work, there is a need to engage religious leaders in the planning of health promotion programs. And generally, a lot of believers, they look up to their religious leaders. They trust them and have deep and close relationships with them. Religious leaders also have a close connection with vulnerable members who might not be reached by regular public health programs. And usually, people's attitude towards public health messages are shaped by their religious beliefs and how their religious leaders respond to the messages. Religious leaders thus are in a good position to inform their members that there is no conflict between public health measures such as social distancing and religious beliefs. Religious leaders are skillful in public speaking and communications. They influence thinking and shape social values and social responsibility through their preaching. Believers are more likely to comply with social distancing when their religious leaders urge them to do so. So the Ministry of Health could work with religious leaders in countering misinformation and sharing scientifically correct and religiously acceptable messages. Since religions teach honesty, it could be used as a resource to encourage truthful sharing of information. Religious organizations in Malaysia could also play a role in disease monitoring, as all mosques and most non-Islamic houses of worship in Malaysia are registered with the government. Many religious organizations, such as Christian churches, also keep a record of membership. Even in religious organizations where there are no official membership records, it is still possible to keep track of the members since they tend to attend the same religious congregations regularly. And within a congregation, people often form smaller and more personal groups. So religious organizations, they are well placed to reach out to the vulnerable groups which are living in poor conditions or who have poor or no access to the healthcare system, such as people living in poverty and rural communities, and prisoners, migrants, and refugees. And many people turn to religion to cope with the stress caused by the pandemic. Religion and spirituality could be integrated into the healthcare system through the setting up of multi-faith chaplaincies to provide spiritual support to patients and their families, and also our healthcare personnel. Distrust towards medical doctors and the healthcare system is very common and may slow down disease control. And many people are more open to their religious leaders than to healthcare personnel. So in addition to chaplaincy services, doctor-patient relationships could be improved through spirituality assessment. Another way to integrate spirituality into clinical setting is to include spirituality and health in medical curricula by training medical students to inquire about religion and spiritual beliefs of patients. Many medical schools have started to do so, including Monash University. Faith-based health promotion programs are effective in improving health. The Ministry of Health should consider funding religious organizations in health promotion. Without strong governmental support, the capability of religious organizations in addressing COVID-19 is very, very limited. And because of a simpler structure, religious organizations could adapt quickly to a health emergency. During the COVID-19 pandemic, many religious organizations have responded quickly and provided various community support, such as delivering food items or providing online prayer. More importantly, for the partnership between the healthcare system and religious institutions to work well, religious organizations should not preach against public health measures such as social distancing, and religion should not be blamed for the spread of the disease. So in conclusion, a long-term engagement between the healthcare system and the religious organizations has a great potential to improve the health of the communities. And religious leaders should always be included as active partners in public health plan. Thank you for listening.
Thank you very much, Tintin. Sorry, Min Min. My apologies for that. Thank you for stopping the sharing. Okay, the floor is open for question and answers, specifically to Dr. Tan on her topic first before I open up to everyone else.
Yeah.
Yes, Steffi.
Hi, thank you. That was a great presentation. First of all, I have to apologize. I have to leave at 6 for an event, a training event, so I apologize. But I just wanted to get a quick question in, which was around religious leadership and gender, because it may just be the slide that you showed, but they were all guys, and they were all, I mean, they were all animated cartoon guys, but they were guys. So is there an impact on how messages get through to older communities, to women, to children, that might be made stronger if there was a stronger presence of women in this leadership pattern that you're looking at?
Thank you for your question. When I was looking for the picture to represent religious leader, okay, this is AI problem, Google AI problem. Like all the religious leaders photo I found is all men. Okay, so so my husband is a pastor. So I have a very close knowledge in this. So from my observation is that a lot of religious leaders, at least in this part of the world, they are mostly men. So of course, what you say is correct. So having just a male-dominated leadership, right, it might hinder the reaching out of the messages. So having more female religious leaders, yeah, it might help to reach out to more female. But then I think in this part of the world, many religious leaders, religious leadership, the position are still held by men, unfortunately. But then the number of female religious leaders, I would say that is starting to increase. So hopefully this will help. Yeah. Thank you.
Thank you very much. Are there any more questions for Dr. Tan? Okay, if not, I will open up to questions for all three speakers. So please raise your hand or type your question in the chat. I can, that's a thank you. Perhaps I can ask a question for Dr. Tan. This is about one of the first things that you said about religion being a health asset. I just want to, ask perhaps a provocative question. Can it be a health liability? And I think you recognize that in your latest slide when you said don't blame religion. But we have been seeing a lot of these messages going around, especially in relation to the vaccination program. Not only anti-vaxxers, but also those who say some of the vaccines are produced using, sort of stem cells from aborted fetuses and so on and so forth. So how do you see religion sort of coming in there? Because there is, for me, a public health good in vaccination.
So thank you for the question. I think again, I think there's a lot of this kind of miscommunication, misunderstanding is due to the people are not engaging the religious leaders in public health program. So just one example, the Ebola epidemic in Africa, in West Africa. So for example, so for Ebola, right, for West African, right, when they want to bury their dead, so they have to clean the dead personally. But then Ebola will spread out like that. So what they do, so they reach out to the religious leader, the imam, and then the pastor. So reach out to them and then ask them to help, ask them to quote the Quran or the Bible to support the fact that there's another way for burial, that you don't have to touch the patient directly. So if you engage a religious leader, I believe a lot of this misunderstanding will be reduced. And in fact, actually, if you look at a lot of religious curricula, so just now I mentioned medical curricula, right? So medical curricula, they have already catch up. So they have courses to teach medical students how to take spirituality assessment. But then if you look at the religious curricula, people who study theology, so I think there is a lack of public health component in religious curricula, okay, from my experience. So maybe we need to train the religious leaders when they go for their theological study, Bible study or Islamic study. So we should train them how to respond to public health emergency. So, and then how to include them, engage them in public health promotion planning.
Thank you. Prof. Gan has provided a comment, an interesting comment about the difficulty or challenge in incorporating religion in health promotion activities where Islam is the official religion. Do you have a comment on this?
Yes.
Would you like to respond?
Yeah. So this comment is about people might misinterpret, like you are trying to convert people using health, right? So my suggestion is when you run all this faith-based health promotion program, you do you reach out to your own members of your own religion, instead of using it as a conversion tool. So you do it within, let's say, okay, I'm a Christian, so I do it in the church. So you reach out to your members. If you're Muslim, you do it in a mosque, reach out to the mosque. And for example, if you conduct a health promotion program in a mosque.
And IT and health professional and academics like yourself to work together on thinking about how there could be a platform that allows one to speak to people's spirituality and to speak to their different religious, what's the word, loyalties, I guess. But at the same time, looking at Gan's comments, avoiding being specific, so avoiding any issue of looking like you're promoting one religion or another, but rather saying this is a way in which different religious leaders can reach people, and sometimes people who may or may not come to the mosque or come to church, but are actually very important parts of the community if they can't come for whatever reasons of being vulnerable. So I don't know, and also younger people that might not be listening as hard as they should in church or in mosque, perhaps, not always.
Thank you. That's really important insight. Would either of our speakers, Min Min or Darwin, would like to respond, or anyone from the floor? I mean, this is let's have an open discussion rather than a Q&A.
So I have a comment on this. So many people would think, oh, this COVID-19 is harming religious institution. People cannot go to church or to mosque anymore. So our church is going to close now. Actually, like for our church, we are adapting. So we run our worship online, all the prayer services, everything online. Actually, we reach out to more people. And because of this pandemic, right, so we also run a health promotion program, and then we teach people how to take care of themselves, and then not just the hygiene and also mental health. So we run a mental health program, and actually because of Zoom, we don't have a limitation, physical limitation anymore, just time limitation. So we are able to reach out to more people, even the young people. If you have a very engaging session, actually young people, they are very happy to join online program. And then because if you have a religious gathering online, right, then you don't have to be stuck in the traffic jam, and then you don't have to travel. So then it's actually if you adapt well, you can reach out to more people, and then you can send out health promotion message more easily.
Absolutely. Are there any other comments, questions, viewpoints?
I think for me, I think religion is quite a sensitive issue, regardless, especially in this region. Even I'm from Indonesia, so it is quite a sensitive issue as well in Indonesia. I think for health-related activities, I'll still, for my personal opinion, I'll still prefer it to be conducted in a more neutral places like workplace, schools. Yeah, because I think all these issues about the anti-vaccines and also all these health-related negative myth that's maybe or that's not true. I think generally it's because of a lack of education. I think we have to actually educate the general public. Yeah, I think of course sometimes it is better to have the professionals to actually come out and to explain all these things rather than sometimes having the religious leader to explain it. Because if you're a religious leader to come out and explain it, then people may have the perceptions that this could be a bit more inclined to that religion's kind of messages or something like that. So that's my opinion.
Thanks for that. That's an interesting point, because earlier in Min Min's slide, she said that if there is less public trust, and there might be less public trust in health professionals, and people prefer to trust their religious leaders. And this
it's true. I think the way I think from what I say, it still go back to the educations. I think we should starting from the school at the school and also at the workplace. I think. Yeah, of course, some people don't go to the church and don't go to the mosque and don't go to the temples very often. I think workplace, I think every one of us have to go to the work every day, and the kids will have to go to the school every day. So I think that will be some of the best place to do. Yeah.
Thanks. Are there any other views? This is really interesting, seeing the connections between all three speakers, all three presentations, using the immersion sort of method that Steffi has talked about for both the other two projects, and vice versa. It's really interesting. We have about 3 more minutes before to 1 o'clock when this session is supposed to end.
Just to add to what Darwin say, so actually what I meant, the faith-based health promotion program, it does not need to be carried out by a religious leader. It is just being carried out in a religious space, and then organized by a religious institution, and then but it can reach out to the members itself. So
Yes.
research have shown that actually faith-based health promotion program is more effective. Yeah, because people are more open to their religious leader, and when, especially when it comes to mental health, I don't know why, like, people rather talk to their pastor or imam than talk to a psychiatrist. Yeah.
Yeah, I do. Yeah, I think for mental health, yeah, I do agree with that. Yeah. I think, I think it's quite common that we talk to them.
Yeah.
Well, we are reaching, almost reaching 1 o'clock. If I can just mention, I know there is a campus research project, a multidisciplinary one, on using, on religious leaders in dealing with public approaches and responses to what they call these conditions like HIV and epilepsy, stigmatized diseases by people, and how religious leaders and religious institutions could or could not help in that. So that's an interesting project between people from the School of Medicine, School of Arts, and also the Malaysia Immersion Hub. So yeah, so I think we are sort of looking at this issue here because I think there is a dilemma. Education is of course the best way forward in the secular setting, but we do find more trust in religious leaders. So that is something really that we need to look at. So if there are no further questions, and if our speakers are happy with all of the comments that they've provided and have don't wish to add anything more, I would like to thank everyone for being here at our first PechaKucha.